Hi, everyone. This is Paul Loberti. How are you? Hope you're doing okay. I'm the Administrator for Medical Services at the Executive Office of Health and Human Services, and also direct the HIV provision of care and special populations there. I'm so happy that you're joining us today. And we have a very special guest, Dr. Joe Garland, whom I'll introduce in just a minute. I wanted to start off by telling you a little bit about this exciting series that we've created. It was something that came out of the Consumer Advisory Board. And it was really exciting when they talked about the need for very, very specific topic areas on HIV and healthy aging. Specifically, we've co-joined with Age Friendly Rhode Island College, and colleagues throughout the state, including Dr. Garland, to bring people a series of events that will be video-based, and they'll show up in the virtual community center at Age Friendly Rhode Island. So we're pretty excited about this endeavor. We'll also plant the videos in other key places that the Consumer Advisory Board has asked us to. So for example, they may show up in community-based organizations, and we're trying to develop a training center that will allow case managers to take a look at these at their leisure and even get credit hours for them. So we want to thank the small audience we gathered today. I'd like you to keep your mics off until we get to the question and answer period with Dr. Garland. But if I could have the next slide, Patrick, and just sort of present Dr. Garland in a more formal manner that you may not be aware of the incredible resource we have in Dr. Garland here. He's a great guy. I met him when he first got to the state, incredibly gracious, and certainly doesn't have any ego attached to the things that I'm about to show you. So bear with me for a second, because I think it's so important that we celebrate the resources we have in Rhode Island. I've always said that given the incredible clinic that the Immunology Center has, we're so fortunate in Rhode Island to have among the best. And certainly Joe is one of the best that I could even imagine setting foot in the state. He's the medical director of the Infectious Diseases and Immunology Center, and he oversees the outpatient services of Infectious Disease Division, including the federally funded Ryan White program there. The services are outreaching to over 800 patients living with HIV, which is absolutely incredible given the fact that we have 2,600 patients living with HIV in the state of Rhode Island. He does so much there, including the travel clinic, the outpatient general infectious diseases consultation services that he's a part of. And he oversees over 20,000 patient visits per year. That's incredible to me. It really is a testament to the volume that not only Joe sees, but his colleagues at the clinic see. The clinical experience that he has in HIV care, I say that he's one of the outstanding HIV-ologists in the country. So I don't know whether that word was coined by me or not, but I love that word because it really helps us to specialize in what we're up to here, and he does it well. He, of course, as I mentioned, HIV, infectious diseases, he knows a lot about it, hepatitis C, travel medicine, care of immigrant populations. I don't know, but he's also incredibly well sort of informed about the pharmacology that goes on in the complicated world of presenting antiretroviral therapy. He co-chairs the statewide 90-90-90 collaborative. He's a member of the American Academy of HIV Medicine's New England Steering Committee. He's an educator, and we see that when he's introduced in many forums that I've been in with Joe. He serves as a preceptor for the Fellows Clinic. He's the course director for clinical rotations in the internal medicine residency program at Brown. He directs clinical courses for medical students at a local community center, one that we fund, Clinica Esperanza. And Dr. Garland received his undergraduate and medical degrees from Harvard University and completed residency and fellowship training at the hospital of yet another Ivy League, the University of Pennsylvania. Whoa, 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 Joe. I'm really happy to have you with us. And I know that you're so busy. We appreciate the time that you're going to spend with us today. And
thank you, Paul. That is, that's an embarrassing introduction. I appreciate your kindness.
I remember when I first met you, I said, "Nice to meet you, Dr. Garland," and you said, "Gee, that reminds me of my dad. Please call me Joe." So I've really always been impressed by your presence and the fact that you are so connected to people and they honestly are connected with you. So we have a few people on the call today that'll ask some questions of you. We've assembled some of our staff, some individuals that are working as professionals in the world of HIV, and some folks that are on our community advisory board. So if I could just have the next slide, what I'd like to do is pre-offer up the questions, and Joe has presented a slideshow for us that'll answer all of these questions. But just for the audience for now, let me tell you what he'll be looking at. I've asked him to talk a little bit about the new immunology center. It's a pretty exciting place. If you haven't been there, and I can understand if we haven't because of the COVID lockdown, they're doing a lot of telehealth visits lately, but he's going to show us some shots of that and talk a little bit about that exciting endeavor and where it's located. Also, I've asked him to reflect upon some things that we're doing in aging and some recommendations he might have for people living with HIV. Next, please. Of course, any stories he had to share with patient struggles. When we were on a case manager committee meeting, Dr. Garland shared some really interesting stories, but they were provocative enough to get our attention in terms of the fact that people may not necessarily be as prepared as they should be. And when it comes to aging, so I've had him reflect upon that, some success stories, and certainly any advisory that he might have for people living with HIV. So that'll get us started. So Patrick, if we can close down this one and open up Dr. Garland's presentation, it'll give Joe an opportunity to talk, and then we can reflect on some questions and have some final remarks as well. But thanks again for joining us.
Thank you so much, Paul. That is too kind, as usual. I really appreciate it. And I'm actually really excited to talk about this subject. I think historically, when we talked about HIV, when scientists and doctors talked about HIV, we tended not to think enough about people aging with HIV. And I think that, a very telling statistic is that 50% of the patients seen in our clinic are age 50 or older. 50 isn't particularly old, but it just is older than we tended to initially think about during the early years of the HIV epidemic. And so, half of our patients are over 50, and a good number of our patients, I think over 300 of our patients are over 65. And so as we have, grown with our patients, I think there's a lot that I've learned from them, and then a lot that I think the HIV providers as a community need to start thinking about. So I think this is a learning opportunity for everybody, for us as well as for our patients. So I'll give you that context. If we could go to the next slide, Patrick. Paul had asked me to give a virtual tour of the immunology center. I can't actually walk you around the clinic right now because we're operating and I can't have patients in the back of my camera, obviously. So I went around. I will say I'm not a great photographer, so I apologize in advance. But I went around and took some pictures of folks, and I wanted to give you a bit of a virtual tour. So if you go to the next slide, Patrick. Just a few facts. So our new address is at 180 Corliss Street. We take up the entire 3rd floor. That's our building right there that you see. Lots of light, which is nice. We also have on site the STI clinic, which for now is appointment only due to COVID restrictions, but we do see patients in person for any STI complaints. And that has nothing to do with people's HIV status. You can come there if you have HIV, you come there if you don't have HIV, but it's also co-located. We have a lab on the 2nd floor, and there's a new Lifespan Pharmacy location on the 1st floor, which has been a great resource to our patients. And we have, when I talk to all of our patients about, what do you think of our new space, everybody's first comment is the parking is so much better. So we have parking right outside the building. You're not parked on a 45-degree slope with the broken asphalt. So we've got that as well. Our phone number is the same. The staff is all the same wonderful people came over. So it's just a new improved space. If you go to the next slide, Patrick. So just a couple of photographs. So this is our waiting room in the 2 photos on the left-hand side. We've got it spaced out for COVID spacing, but it's a nice open, airy waiting room area. Many of you, if you're patients in the clinic, you know Donna, who's been there forever. That's Donna sitting at her desk. It's a nice open space. And then our exam rooms look like pretty much any other exam rooms. There's an example up in the upper right-hand corner. We have bulletin boards up. Pretty much everything that is up on the boards is in English and Spanish for patients. We try to keep it updated with information people might need, research trials, et cetera. If you go to the next slide, we have a nice two nice conference rooms, which someday will be in more use. This was from earlier in the year when we had staff in the conference room. There's Dr. Bird and Dr. Johnson seeing a patient in clinic. And in the bottom right, you can see Dr. Wunsch and Maria, one of our staple, one of our long-term medical assistants. So just sort of a sense of what we have in the space. The main important part of what we have really is the people. And so the next slides are just to talk a little bit about some of the folks that we have in the clinic, if you're not already familiar with our services. So if you go to the next slide, Patrick. So yeah, you may have encountered our two wonderful pharmacists. So Dr. Shaw and Dr. Brotherton are our two ID specialist pharmacists. So they actually have training beyond their pharmacy degrees. They also have additional training specifically in HIV and infectious diseases. So they are a wealth of knowledge. We have three wonderful social workers, Emmy Wiper, Tatiana Ramirez, and Ashley Amaral. They're wonderful, and they are there to provide any services that folks need around social work. We are lucky to have medical case management nurses, so two nurses who specialize specifically in medical case management for complex folks with HIV. So Donna Nunez and Cindy Vinciguerra. And then our clinic nurses, I think folks have probably already met if you've been in. They give the vaccines, they help set up any appointments, they handle all the phone calls when people call in with concerns. So Maria, Maddie, Leah, and Giselle. And then our outreach workers, I think most folks are familiar with. They help folks with all things insurance related, co-payments, medical bills, et cetera. So Cassie and Melissa, that's Cassie sitting there in their office. And then we have two folks who are working remotely. They're our pharmacy liaisons. They help with all of the crazy paperwork around a lot of the HIV medications we prescribe. They help make sure that the prescription as written by the provider actually makes it to the pharmacy and is affordable to the patient. They make sure that the prescription's ready when the patient arrives. Any issues that come up, they troubleshoot. They've been an amazing addition to our team. So these are the folks who really sort of make things run smoothly in the clinic. The next slide, we have a couple of wonderful specialists who, are specialists in their own areas, but also have gained an expertise in HIV care. And so we're really lucky to have them. So we have three members of our mental and behavioral health team. I don't have a picture of Dr. Pinkston, but I think a lot of people already know her. That's Dr. Nick Tarantino, who was with us a couple of years ago as a fellow and then has joined the faculty. So we get to keep him, which is great. And then Dr. Christina Skelly, who's our psychiatrist. Dr. Mary Flynn is our nutritionist, and she really has taken an interest in over many years in caring for people with HIV. So she is able to offer nutrition counseling specific to HIV. We have the STI clinic is on the third floor, as I said, lab on the second floor, and Lifespan Pharmacy on the first floor. So the idea when Lifespan was putting together this new building was really to try to pull all of these resources together in one space as much as possible, so it can be one-stop shopping, that patients can see the provider, work with any of the staff that they need. They can get their labs drawn, they can pick up their prescription and walk out of the building with everything in hand. What our latest addition, which I'm super excited about, and I think in my very first week in Rhode Island, when I met with Paul, I talked about this was a dream that I had. I don't know if you remember this, Paul, but I have always felt that having the ASOs, having the community agencies that work with people living with HIV, have touchdown space in clinic, have the ability to meet with patients in clinic is so important to linking people to care. And years ago, we looked at this and we found that 50% of the referrals that we made, people didn't connect to the ASOs. And, I don't think that was anybody's fault, but that's a systems problem. So we actually have created an office. We have, so Maritha's in there, but we have folks from all three of the ASOs that serve people living with HIV in Rhode Island come in and rotate using the office space, so that if I'm seeing a patient and they need to link to an ASO and they haven't been able to, I can now walk them down the hall and they can meet with someone right there. So that's I think an incredibly important addition to the space that we have.
Yeah, I do remember that, Joe, and you've done such a great job. I'm seeing Dr. Carpenter just applauding you from his new seat. Chuck Carpenter, of course, to all of us was the founder of this, and your dreams and your realization of those dreams are really incredible. So I think bravo, bravo.
Well, thank you. To be associated in the same sentence with Dr. Carpenter is the highest of compliments. So thank you. Dr. Carpenter founded this clinic 31 years ago, and it really has continued forward with his vision. So thank you, Paul. If you go to the next slide, those are the folks that you'll see. I tried to give you a little bit of visual of the space. It's nice, it's airy, the ceilings are higher. There's not lots of air, lots of light, so we're very happy with it. Importantly, we've really tried to build out resources. We've had many conversations with the folks at EOHHS, with folks at the Department of Health since the beginning of the COVID pandemic about how we can help our patients better with some of the issues. So this is not specifically related to HIV and aging. This is for all of our patients, but on site we have assistance with insurance enrollment, ADAP enrollment through our wonderful outreach workers. And we've developed a number of Ryan-wide assistance programs in coordination with the EOHHS. So one of them is health payment assistance. We've had this for a very long time. So if people meet eligibility criteria for Ryan-wide services under the state definition, we will help them, any bills they get from clinic or for labs, we can help them through our own grant funds pay for that. We also recognize that the state offers dental coverage, but that is still limited. Sometimes the people aren't able to get on coverage, et cetera. They may have a dental emergency that they didn't know that they should have signed up for dental services. So we do have set up a program to offer assistance with dental bills for patients as well. There's our newest programs are around emergency food assistance, our food bank program, and over-the-counter medications. So just to speak briefly to those, we talked to many patients in the beginning of the pandemic, and I think access to food was an issue, and a lot of the ways people traditionally, access groceries were not open to them. So we ended up setting up an emergency food assistance program where we gave out gift cards to Stop and Shop and Urban Greens, and we have continued with that. Although we found that many of our patients, it's an ongoing concern, and so we set up our food bank program, which is still gift cards, but people can enroll who are income eligible, and you can enroll for 6 months just like you do for ADAP, and then you get a gift card every month. It certainly isn't enough to pay for all of your groceries. We don't have unlimited funds, but it is a Ryan-wide service that can sort of help supplement people who are also, working through SNAP and working through using, food banks, et cetera. And the last thing is, I always found it so personally frustrating that some of my patients would have a cold and, they didn't have money to go buy Theraflu or something like that. And like, why should they have to suffer with symptoms? And so we set up a program with Lifespan Pharmacy downstairs. So if you need Tylenol or ibuprofen or Theraflu or whatever, we can use our Ryan-wide funds to pay for it. Your prescriber just has to send a prescription downstairs and notify the social workers. For anybody who's income eligible for Ryan-wide services through the state, we can cover the cost of those medications through the clinic. So it's a way for people to, have things that are not life-saving, but certainly are affect your quality of life when you're feeling ill. I have a terrible example of a patient of mine who stopped taking his baby aspirin after having a heart attack because his insurance wouldn't pay for it and he had to pay for it. And he said, it's not a lot of money, I just don't have it right now. And so that's ridiculous. So we cover that through our Ryan-wide program as well. So those are some of the assistance programs we've built up over the course of the year when we moved into this new site with the ability to have all of our team in one place, have the pharmacy on site, et cetera. So I'll stop talking about the immunology center because this is actually mainly about HIV and aging. So let's go to the next slide, please. So Paul was kind enough to send me the questions in advance. So I just wanted to sort of try to give a little bit of framework of how I think about as a clinician HIV and aging. I'll try to go through these pretty quickly just so we can open it up to questions. If you go to the next slide. I think when I think about HIV and aging, there are a bunch of different areas I consider. I'm certainly like not a world expert on this. I sat down and when Paul asked me to do this, I sat down and read a bunch of review articles on HIV and aging, and they were incredibly informative to me around the medical perspective. But I think what Paul alluded to earlier has really rung true for me, that the biggest thing that I've noted with patients is not specifically around their HIV medications, but around changes to health insurance, social situations, housing, et cetera. So when I think about HIV and aging, I think a little bit more broadly than just the strictly medical scope. So these are sort of the six main areas I think about: sort of health screenings and vaccines, medical conditions associated with aging, but also social changes associated with aging. Specifically health insurance, planning ahead around wills and who make decisions if you can, et cetera. And then housing and in-home needs that might change. So those are the six areas I'll talk. I have just one slide on each. Then we can sort of open it up for discussion. The next slide is probably my busiest one, but the health screenings and vaccines. So as we age, we need to think more about screening tests and vaccines to keep ourselves healthy. So this is not for people who are sick, this is for everybody who's healthy. These are things that your doctor generally brings up in your annual physical, but just be aware that these are also things you can ask about if your doctor doesn't. Doctors have lists of things that if they check off all their boxes will probably take an hour, and they may not have an hour with you. So they may miss something, and it's also totally within your right to say, actually, I have a question about this thing. So I just sort of put it by advancing age here. Colon cancer screening is now recommended over the age of 45. It used to be 50, but now over the age of 45. Breast cancer screening, which is usually a mammogram, it depends on the society you're following, but it's generally age 45 to 50 is when it should be started, and it's usually an annual screen. Something that differs from people who don't have HIV is bone density screening. So both some of our older medications that include a formulation of tenofovir called TDF, and HIV itself, both of those can independently affect bone density. And so we know that people living with HIV actually have a higher risk of osteopenia, meaning thin bones, or osteoporosis, which is a more extreme of thin bones. Why do we care about that? Because that puts people at a higher risk of having fractures. So we want to diagnose it early because there are things we can do. Make sure people are getting enough calcium and vitamin D, make sure they're on medications that can support their bone density, and that they aren't on medications that are harming their bone density. So bone density screening is generally recommended over the age of 50. That can be a DEXA scan, which is sort of a fancy type of hip x-ray. That can be through calculating what's called a FRAX score. There are different ways different providers do it, but having a conversation over the age of 50 about bone density screening is appropriate for all people living with HIV. Also, shingles vaccine. There was a lot of controversy back in the day about the old shingles vaccine, which was a live vaccine. And there was question about safety and effectiveness in people living with HIV. The new shingles vaccine is better for everyone, is not a live vaccine, and should be offered to people living with HIV. In fact, the Ryan White, the National Department of Health and Human Services that we follow their guidelines, all Ryan White clinics do, has said they recommend the vaccine in all people over the age of 50. So that's something that it's sometimes hard to find because they don't produce quite enough. So, every clinic's always sort of running out, but that's something you should ask your doctor about. Prostate cancer screening is a little more
Joe, I'm not sure.
Sorry?
Oh, I'm sorry to interrupt, but I'm not sure that's currently on our formulary, so we can make that happen so that the shingles vaccine, the new shingles vaccine gets on the formulary. So it'll make life a little easier for folks. So we can take a look at that. I know Denise is on the call, our new ADAP coordinator. So if that helps, we can make sure that that's available.
Oh, that's great, Paul. Thank you. That's a great idea. In terms, we do usually stock it in clinic. It can run out. And if it's not covered by people's insurance and they are Ryan White eligible, like we usually use clinic funds to cover it because it's now recommended.
Okay.
So thank you. Prostate cancer screening is controversial. So for folks over the age of 50, discuss it with your provider. It may be appropriate, particularly if you have a family history, but it's not something we routinely do for everyone because there's such a high false positive rate that you don't want to cause people harm by having them get unnecessary biopsies. So it's something that is now what's called shared decision-making with your doc. Lung cancer screening in smokers is supposed to start at age 55, and aortic aneurysm screening, what is that? That's basically your blood vessels are supposed to be nice straight tubes. One of the largest one is the largest one in your body is your aorta, and when it goes through your abdomen, sort of behind your intestines, in smokers there's a higher risk that it can start swelling a little bit like hose with a weakened area. If you sort of step on the hose, you can see this hose bulge there. It's the same idea with an aortic aneurysm. So that's a screening test that we do through an ultrasound for people over the age of 60. I put two other things that I think are not age directed, but should be always on our minds. One is sexual health screenings. One of the things that I've noticed is that we do less STD screening as people age, and I think that that is inappropriate. I think that we still need to offer STD screening to everyone who's sexually active, but some providers may not think about it in their patients as they age, and I think that you should certainly ask for it. I think in general, our sexual function changes as we get older, so I see many of my patients who are uncomfortable to raise the question of for male patients, erectile dysfunction. For women who are postmenopausal, they sometimes have more pain with sexual activity. Both of those are things that there are medical treatments for. There are and even if you don't want to take a medication, there's certainly things that you can talk to your doctor about. So both around sexual activity, how to have healthy sex, as we age, and the changes that happen with our body, and also sexual risks. So, making sure that we get appropriate screening. So if your doctor is not bringing it up, please bring it up with them. I will, as a side note for men, note that HIV is associated with low testosterone, and that can become more prominent in terms of symptoms people have as they get older. So we will sometimes screen people for low testosterone if they are experiencing lower libido, or if they're just having increased fatigue or more sort of general symptoms. And then COVID vaccination. So within the next few weeks, the Department of Health is going to recommend that the vaccine be available to all people over the age of 16 who have any qualifying underlying conditions. So HIV does make it on that list. So within a few weeks, all of our patients living with HIV, all people living with HIV in Rhode Island should be eligible for vaccination. So as soon as we hear the official word from the Department of Health, please call your doctor's office or go to one of the state, the website to set up an appointment with one of the state vaccination clinics. Okay, so that was my most busy slide on health screens and vaccinations. Other things I want to talk about, some medical conditions to consider with aging. I think cardiovascular disease is the one that's on people's minds a lot, heart attacks, strokes, things like that. As we get older, it's natural for our kidneys to slow down a little bit. And so there are naturally age-associated kidney changes. We do know that some of the medications for HIV, and again, HIV itself, can also cause kidney damage in some people. So that's why we get labs on folks regularly to monitor for that. But that's something we have to sort of think about. Cancer risk, there are some cancers that are more associated with HIV, but the majority of our patients, it's just the usual screening stuff I spoke about on the previous slide. I've had many of my patients come to me with memory change concerns. I will say the majority of the time, those are the same memory change concerns that anybody has as we get older, like we all forget our keys a little bit more. There is a sort of a grouping of HIV-associated neurocognitive dysfunction, which abbreviates to HAND, like HAND, H-A-N-D. And so we can do memory testing with people if they're concerned that that's the case. I'll say it's rare that we actually end up saying that that's the main thing going on. More often it is age-related memory changes that we all have to sort of adjust to, but it's an important thing to think about. Everybody, as we get older, sleeps less, and everybody has a little more trouble sleeping. thinking about that and how we can make the most of our sleep is important. So that's a good thing to talk about if you're noting it. And pretty much everybody over 40, including myself, needs glasses. So visual changes are a common thing to bring up as well. Your doctor may not think of it, but if you're noticing more headaches at the end of the day, if you're noticing things are looking blurrier, bring it up because you may need glasses. We talked already about bone density changes. We talked about changes in sexual health. And in reality, the unfortunate reality is that as we get older, generally we accumulate more medications to take, more doctors that we need to see, more appointments, and that can be complex for folks who are juggling a lot of other things. So I think those are all important areas that I think about when I'm thinking about caring for our patients as they age, and areas that you should think about. Do some of these resonate with you? Please bring them up with your doctor. And if you don't have enough time, you can always schedule another appointment. So if you don't feel like you got everything and your doctor says, great, see me in 6 months, you can certainly walk up to the desk and say, actually, could I see Dr. Garland again in a week? I had a few more things I want to talk about. Totally fine. Or can the doctor do a telehealth visit with me? Feel free to advocate for yourself. We don't always know what's on your mind, but it is our job to take care. We literally get paid to take care of you. So please advocate for that. On the next slide are things that I'm not an expert on, but I want to make sure I touch on. So as we age, people generally are more independent in both a good way and a bad way. If you have kids are out of the house, there's more independence there. People may have more financial independence because they're not paying for their kids, or they may, have, worked off their debt from college, or they may have bought a house. So there are a lot of ways that we are more independent, but independence can also mean that you're more on your own. So that's an important balance to keep. Caring for aging parents, caring for aging loved ones, the loss of loved ones are all things that happen to us more the older we are. So things that are social supports and social stressors. New relationships, many of my patients are not dating the same person they were dating when they were 20, and that's a good thing, but it may bring up sexual health questions. It may bring up, the things we talked about earlier with, changing sort of how people have healthy sex lives. Insurance changes in Medicare. We're going to talk about that on the next slide because it's a big one. And then retirement, which can have a significant change in people's finances. So it's in a direct response to Paul's questions, if we go to the next slide, I wanted to just talk about one of the big things that's complicated in our country. So health insurance is incredibly complicated in the United States. And one of the most vulnerable places that I have identified, and Paul and I've had several conversations about this, is really that transition to Medicare. So Medicare is wonderful in many ways in that how it has comprehensive coverage, but it is actually very complicated. I am not an expert in this. Case managers are. So I say, if you are having a significant change in your income, new job or job loss, promotion, whatever, if you are about to turn 65 and go on Medicare, or if you're not turning 65, but you are about to go on Medicare because you have SSI or SSDI or whatever, talk to your case manager first, okay? So that you can plan ahead. Also talk to your case manager if you're getting a lot of medical bills. There's often ways that we can help with that. And if you have copays for your HIV medications. The thing about Medicare, there are a couple of them. One is that there's, as you probably have heard, like the donut hole, people have talked about that, or the Medicare gap until you reach catastrophic coverage. There are many, many things that people never had to think about if they were, say, on insurance through their job, or they were on insurance through Medicaid, and then they become Medicare eligible and they sign up for Medicare and they lose their job insurance, they don't sign up for Medicaid, and suddenly they go to pick up their prescriptions in January and discover that they owe $3,400 for that prescription. ADAP can help. That is one of the main supports of the ADAP program, is people going on to Medicare. So that's out of Paul's office, out of UHHS. Also, there are a lot of programs, even if people aren't ADAP eligible, there are pharmaceutical programs, and we are usually able to get patients on meds. But one of the biggest areas of vulnerability for people falling out of care, losing their, or not filling their medications and stopping taking their medications, we have found in our clinic, is this transition to Medicare. So it's nearly impossible for most individuals who are not healthcare professionals to figure out how to make this transition. So it's an important time to reach out to the case managers. And if you don't have a case manager, you can call our clinic and we can help you, or you can reach out to any of the amazing ASOs and they are expert at dealing with this. But this is an area of vulnerability, so think ahead for that. And also towards the end of every year, October, November, December is a time when open enrollment happens. So if you need to enroll in a plan, that's when to do it. And then January is where the Medicare funding resets and you go back to, to having to start paying copays until you reach catastrophic level assistance. And when people reach catastrophic level assistance, it's different for different folks, but it's usually around like $8,000. Most folks don't have $8,000 to pay out of pocket. So think ahead about these things, but there's assistance at your doctor's office and call the ADAP office. They are expert at getting folks into with the ADAP program or to the case management. Anything you wanted to add to that, Paul?
There you go. Sorry about that. No, I think you were really very thorough. As you said, there aren't a lot of people on the streets that are really completely educated about Medicare. So going to your case manager and working with our ADAP program really does help. There are significant issues and a lot of confusion between what Medicare is versus what Medicaid is. And those are elements that show up from time to time when people think that, for example, if they're going into a long-term care facility, that Medicare will pay for that. It won't. Medicaid will, though. And there are all kinds of issues, as Joe mentioned, that are very complicated. And Medicare is run completely by the federal government, and Medicaid is sort of a hybrid of both the state policies as well as the federal policy. So it does get confusing, but I know that a lot of our members of our Consumer Advisory Board bring it up during our meetings, and I feel like we have a lot out there. But this was excellent, Joe, because it really gives people an idea of what they should have in terms of heads up before they get to a certain age.
Thank you. So I'm happy to answer more questions on that in a few seconds. I'll just finish with the last few slides here. The other things to plan ahead, sort of outside of the insurance stuff. So think about your will. So many of my patients are identified as LGBTQ, and they can actually have sort of complex family structures. There may be blood relatives who are close or not close. There may be children. There may be they may be in relationships with partners. So think about what happens to your stuff if you're not there, and make sure that you're protecting people you want, and make it clear who should be responsible for taking care of what your wishes are if you're unable to make them. So a will is an important thing to think about. Think about a power of attorney and think about an advanced care directive. So the advanced care directive is the one I'd focus in on right now, but it's really like when you are, the two things I'd like you to think about in a healthcare context are, if I am unable to make decisions for myself, who do I want to make decisions? And what decisions can I already tell them that I would want? And that may be, do you want to be on life support if that comes up? Would you want major surgery, et cetera? So these are discussions you want to talk to your family about beforehand, and also specifically designate someone, especially if your designee is not someone that would be obvious. So it can be, again, complicated if you have adult children. They would be the natural person next in line unless you are legally married to somebody. But if you're not legally married to someone, but you want that person to be your healthcare designee, then you'd want to make sure that that is stated. So these are things that actually can also be discussed at your doctor's office. You might not think, oh, I should ask my doctor about this, but you can. Again, I'm not a legal expert, but that's why we have social workers in our office who can go through these things with you. I also know a little bit about it. This comes up a lot, but these are things you should talk to your doctor about. I can't help you write your will, but we can help you sort of make it clear in your medical records what are the things you would or wouldn't want done, and who's the person who makes decisions if you can't. So think about those before you ever have a problem. All right. Good. Last slide or next slide. think this is my last slide. So the last area that I deal with a lot with patients, and this is a incredibly complicated area, but as we get older, sometimes people have more needs, and we need to sort of decide what's the best housing situation for that person. Do you want to continue to live independently with some in-home assistance? So I spend time, completing forms to get home health aides for patients. That can be the most, that's sort of the smallest level of change. Sometimes people need to be in a place where they can have medications given to them, some basic, food and stuff supplied, an assisted living facility. And then sometimes people actually move to live with family members and have the family members, help support them. And then nursing homes, where people actually have a higher level of need medically than an assisted living facility or a family member could provide. So thinking ahead about those things, thinking about, your loved ones who are older than you and what their needs are, having those conversations ahead of time with your provider is a good idea as well, so that you can talk about how do I access this resource? Is there going to be a waiting list if I want to do that? Should I sort of preemptively put an application in, et cetera? So there are many options around housing and home needs, but discussing this with your provider and case manager are a great thing. I've had some really, heart-wrenching stories of patients who ended up, losing their housing, and, being homeless and in your 60s and 70s is complex if you're also medically complex. Well, it's complex for anybody, but it's particularly complex if you're also medically complex. And we don't want to end up in that situation. So the more we can think ahead, the better. So I will say that I spread a little more broadly my gentle criticism of most of the medical literature I read around this, as it focuses so much in on the aging of people around the medical realm, that the complexity that I actually feel like we deal with most of the time in clinic are all of these other areas. So I wanted to sort of put them out there for the group as well. The upshot of all of this is these are things that you can bring up with your doctor and should, and that case management, either medical case management in the clinic, social work in the clinic, and our outreach workers in the clinic, or in the community, the really amazing support from the case management at the community-based organizations, have a lot of these answers and can walk people through these resources.
Well, great. Thank you. Thanks a lot, Joe. As you were talking, a very provocative sort of thing came to mind, whereby when I first started in the field almost 30 years ago, we weren't having conversations about people living with HIV aging. And as a result of some incredible phenomena in terms of our pharmacology advancements, as well as our clinical care advancements, and all of the other things that have been in place, and thanks to you all at the Immunology Clinic for sustaining life, we're having this conversation, and we're having this conversation whereby if again, I could relate to a lot of these things because I am in fact aging in place like we all are, but I think I'm moving along a little quicker than I ever expected. But the reality is not only can the broader population relate to this, it's not an uncommon thing that HIV in and of itself is causing people to age more dramatically or more sort of advanced than others. So to me, even though aging sometimes is a difficult pill in and of itself to swallow, it was incredibly encouraging, incredibly upbeat. And for those of us who have been with this for a long time, we're just really excited about the messaging that you offer us today. So I want to thank you again. And also, I want to open it up to the group at this point, because we have a lot of people that have not only been following some of the work of the Immunology Clinic, but following the work that you've been doing. And just by the fact that we opened up with this new exciting clinical space, that seems to be almost as a medical mall of sorts, where you can get so many wraparounds, and you're so connected with our AIDS care organizations that it's phenomenal. That isn't happening in all states. I want to let people know that, because I sit on a lot of national and international boards. I don't see a lot of this social responsibility and community development to the heights that you all have given it. So again, thanks for that. But let me open it up to the group. And do you have some questions for Dr. Garland while he's with us? And if you do, please just let us know and we'll have you turn on your mic. I did get some from people, so if we have a lull here, I can read some things that people sent me. I know we have a great group here, so. Teresa, go ahead, please put your mic on. Royal.
Yes, royally a pain or what? But I know Dr. Garland also. Dr. Garland,
yes, we do.
You've always been great. We've sat on meetings. He's also been my doctor before. But some of the ideals that he's put forth in the clinic area, some of the things that we also talked about, and also too, some of the necessities that have been going on. And regards to some of the things that have been going on within the state are very important that were also brought up, and in need of getting the vaccine, which is a big thing that is going on. And what my doctor went and said to me is to leave it up to immunology to pass that on to me. Now, if that is the case, because immunology has been the forefront and care for a lot of the community that we represent, then would immunology also be in care of the COVID vaccine and the other vaccines that we were talking about today, such as the shingles and things like that were mentioned today?
Excellent. It's nice to see you, Teresa. Excellent questions. So yes, absolutely. So first, for all other vaccines, essentially, they're most of them are provided from the Department of Health. So much appreciation to the Department of Health for providing those to clinics across the state. And all the vaccines that we talked about today and all vaccines indicated in people living with HIV, we stock in the clinic. We can give to you if you do get a bill for it. And you shouldn't, they're all covered by insurance generally. But if you do get a bill for anything, before paying any bills out of the clinic, just call the clinic and make sure that you aren't eligible for a Ryan White program. It turns out that 98.2% of the patients that are seen in our clinic are Ryan White eligible by the state criteria. EOHHS, several years ago raised the eligibility criteria that really allowed access to many more people. So almost all of our patients do meet financial eligibility for Ryan White. So, so yes, vaccines are eligible. Are available in the clinic, and yes, you usually can be covered through one way or another. To your specific question about the COVID vaccine, yes, so we felt the same sense of responsibility that you put on us, that we want our patients to be able to be vaccinated. The vaccine supply to the state comes to the Department of Health, and they distribute it across the system. And Lifespan gets a supply, our healthcare system gets a supply. And we said, if you give us vaccine, we will give it to patients. And so I will say it is an incredible privilege to work with such amazing people, because basically our entire staff has volunteered to run vaccine clinic. So the way the vaccines come, and they come in multi-dose vials. So once you open the vial, you only have a certain amount of time to use those doses. So we can't just have it sitting in clinic and give it to people as they come in, because then we would be wasting all this incredibly valuable vaccine. So vaccine clinics have to be set up separately and basically grouped in 5s or 6s, so we can make sure we use all the doses in a vial in the time that we have allotted. So our clinic staff basically volunteered to stay late. So we run vaccine clinic from 4 to 6 several days a week, and on Saturdays now. Because the supply comes from the Department of Health, it goes, we have to follow the state guidelines on who's currently eligible. So current eligibility is age 65 or greater in the state of Rhode Island. So and we are open to folks from the community as well. We have said we will run as many days as you give us vaccine for. So it's, what do we get? And then what days can we fit in? So it's currently, I think we're running 4 days a week, including all days on Saturdays. For our immunology patients, we actually attempted to reach out to all of the patients who were age eligible, so 65 or older, and say, can we get you in for a vaccine if you'd like it? Yeah, and within about 2 weeks, the Department of Health predicts that they will broaden the eligibility to all people over the age of 60, period, and then anyone over the age of 16 with eligible underlying conditions. And as I said, HIV is included on that. So at that point, all of our patients will be eligible. So we will, again, be trying to reach out to folks. So if you hear it on the news, feel free to call the clinic and schedule yourself for an appointment. The appointment availability is based on how many vaccines we get. So there may be a delay based on that. But yes, we already started doing this about 4 weeks ago. And I cannot emphasize, like, it is the most, I can't think of the words, but it is so incredibly inspiring to work with people who, work a 40-hour-a-week job and then volunteer to stay late 4 days a week and come in on the weekend to make sure that we get vaccines into people's arms. And that is absolutely the spirit of the clinic that Dr. Carpenter started here. So, so yes, as soon as it's eligible, and you don't have to be a patient with us, like, we're open to community folks as well.
Great. Thank you for that, Joe. Thank you for the question, Teresa. Anyone else have a question for Dr. Garland? So I did get a text from someone who was said that they didn't feel comfortable asking the question to Dr. Garland, but Dr. Garland, you look so great. You look like you're about 22. Do you have any suggestions on what people can do to stay healthy? And would you be willing to share some things that you do?
Well, thank you. If folks are interested, I'm turning 43 in a month, so I'm not over 65 yet, but I mostly think it's good genetics that I still have mostly dark hair. But thank you for the compliment. In terms of, I'll say first of all, follow your doctor's advice, whether the doctor follows their own advice. Just because they don't follow their own advice doesn't mean it's not good advice, right? So if you have a doctor who smokes, like, you still shouldn't smoke just because your doctor smokes, right? But I will say the things that I do as I try to exercise regularly. I mostly cook my own food because studies have shown that cooking your own food, you generally cook healthier food for yourself than ordering takeout. So we try not to order takeouts too often, although we have been a little bit more to support, some of the restaurants we love. Those are, I think, the big things. We always joke that doctors are the worst patients, but I'll say I do actually see my primary care doctor regularly and, get my usual, labs and screens and everything like that. Thank you for the compliment, but it's not anything different than what I would tell my patients. Try to live healthy, and if they find something wrong, try to get it worked up appropriately. Thanks.
Good. Another one came in this morning for somebody who couldn't make it, and they just asked, do you ever recommend supplements for individuals? The Community Advisory Board has been talking a lot about their interest in some of the vitamin supplements, particularly in terms of their ability to overcome some particular things. Vitamin D comes up often in that group, but this particular person is asking, are there things that should be discussed with your doctor around supplements?
So that's an excellent question, and it's a complex one. The good and the bad of supplements is that they're freely available over the counter, and that's great because then people can sort of take something that they'd like to try without having to sort of go through lots of hoops. But the downside of that is if you're taking a chronic medication, sometimes there can be drug interactions. So the example I will give is multivitamins, calcium, magnesium, zinc. All of those can interact with integrase inhibitors. So, which is a component of Biktarvy, it's a component of Genvoya, it's a component of Stribild, Tivicay. Juluca. So a lot of the meds that our patients take can have drug interactions with things you get over the counter. So I will say in general, supplements are usually not harmful. That's why they are available over the counter. But they can have some significant drug interactions. So I'm generally supportive of the supplements my patients want to bring. I just want to know about beforehand. So that if they're taking a multivitamin, I can talk to them about making sure they're separating it by enough time from their Biktarvy, for example. And then vitamin D deficiency, I will say, is very common. It's something we usually get from the sun, and we don't get as much sun up here in the Northeast as other parts of the world. So a lot of people are vitamin D deficient, and that's something you can certainly ask your doctor about. And taking vitamin D supplements generally is not harmful if you take it at the recommended doses, but people can overdose on it. So I wouldn't take more than the recommended dose. And if it's paired with calcium, make sure you talk to your doctor, because there's that interaction with the HIV meds.
So thank you, Joe.
Well, I have a question.
Yes, please.
Go ahead, Lucille.
It's Lucille.
Hey, Lucille.
Hi. Dr. Garland, one of the things that's come up with the CAB is the issues around behavioral health. 100 years ago, when Paul and I worked together and we were starting the syringe exchange program, we had a substance abuse counselor at the syringe exchange sites. We used to call him the schmoozer. And he would be there to kind of help out, troubleshoot with folks. If they decide they want to be in treatment, he would, talk to family members or whatever. But he was just there on site, and he would help with referrals and that sort of thing. Do you see a need? Are you hearing people come in with behavioral health issues? I know people are struggling in recovery because they're not in the peer support groups. And just normal people are having trouble with their mental health right now. How's that going for you?
Thank you for bringing that up, Lucille. That is an incredible. I think everyone in healthcare, I see Teresa nodding emphatically there. I think everyone in healthcare is seeing this, not specific to HIV at all, but like much higher rates of social isolation, of depression, of anxiety, of people, struggling with psychiatric concerns, with behavioral health concerns, with substance use disorder. It's a tough time for everyone. And so, yes, we are absolutely seeing that in our patient population, which I think reflects what we're seeing in the country. If you talk to mental health clinics across the country, all of them are like overbooked, double booked, triple booked, booked months out just for access issues. We ourselves have been, highly overbooked. We added a third social worker. So Tatiana Ramirez joined our group as a third social worker in January, because we just have more than we can handle with our 2 social workers. And Dr. Tarantino joined us as a psychologist. Again, we're trying to add an additional psychologist and additional psychiatrist over the summer as well, for that exact reason. You brought up a specific example around substance use, and I think that we've also unfortunately seen that. Paul and I were on a call yesterday, actually, at this, and many of us were at the CPPG when we heard the very sobering numbers from the Department of Health about overdose in Rhode Island, numbers climbing as well. I think one of the struggles we have now is exactly what you pointed out with how we used to do things and how we identify patients now. It used to be that we could have someone hanging out the syringe exchange program. With COVID and everything, it's a lot harder to make in the moment connections. And I don't have a great solution for that, a perfect solution for that. Although I will say that we had a Zoom support group. I know that ACOS is doing support groups as well. In terms of accessing buprenorphine at Lifespan, we've got a group of providers together to help people start on Suboxone, like through telehealth visits. So we're behind the ball on this 100%. We as a state need to get ahead of this more than we have. But I think it's certainly something we're recognizing. And those are some of the things we're trying to do, is increase our own mental health and behavioral medicine capacity around substance use as a system, try to meet people where they're at so that they don't have to come into visits and something like that. They can do it through telehealth. But it's a work in progress.
Yeah, I know some of the folks on the cab, we were asking them about case management goals and how they were going. And it was, what somebody made the comment, well, they need to be adjusted. The case management goals that you may have written with your client when they first came in before COVID are not applicable right now because they're in a different kind of crisis.
Yeah, that's
Agreed.
That's right. Yeah, and we're hearing that often. Thank you very much for the question and for the answer, Joe. Appreciate it. I think one of the most important things that I heard from Joe is, consult with your doctor if you have any questions about vitamin supplementation. More importantly, keep an eye on yourself. It's okay to admit that things aren't going right. It's okay to seek help for those things that you're feeling right now. We're all feeling them. And sometimes it takes a little more to come forward and ask for that help. But I certainly ask all of you not to wait, but to, call your physician, get in touch with someone, and really try to work these issues out, because they're really, it's plaguing all of us, and we're in a very difficult time. Hopefully things will open up a little bit for all of us, and hope will be back on our list. But right now, take care of yourself, take care of others. I know a lot of community advisory members, or consumer advisory members rather, have told us that they live in apartment complexes with other people who are on the cab, and they take care of themselves. They check in. And some that don't live near each other, they call, they create a Zoom call or a FaceTime call. So that's the kind of stuff that really exemplifies our community. And I think more than anything, we started off this session really talking about HIV and healthy aging, but what it really is about is an incredible resource that we have in our community. Dr. Garland, thank you for being that resource. Thank your staff for the incredible work that they've done, not only during COVID, but for at least the distance that I remember them being there. Maybe they're not all the same people, but in 30 years, it's been a remarkable journey to see what's in front of us here in this picture. It is wildly expressive of your thoughts, and again, the vision of that pioneer, Dr. Carpenter. He started off, by the way, really focusing on some very, very out-of-the-box thinking, and he got us all thinking about it. He was one of my mentors, and I'll never forget the day that I met him. He asked me to come to the clinic and really do a walkthrough because we were funding them at that time, and we were one of the only funded, we were only one of the funding sources. And, it was really wildly amazing to watch him work. And I see a lot of his character in you, Joe. So thank you so much. I want to thank everybody else. I'm looking at the time. We definitely spent an hour plus together. That went by so quickly. Thanks for the questions. I want to thank the individuals who have helped us get this series going. First, let me start with Age Friendly Rhode Island. They're not here today, but all the participants that have made this possible. Patrick O'Brien from our staff, Amber Rusher, as well as Brianna Saucier, the interns that have worked very hard on creating a project plan to make it work. And of course, thanks to all of you for asking us to bring this topic to the forefront. Rhode Island is really progressive in this area, and I've checked with other Ryan White programs. We're speaking about it head on. We're speaking about some really difficult issues, and we're also creating community resources to back it up. So again, thank you all for your participation. Again, Dr. Garland, thank you for your wonderful discussion today and for your honesty and upfront approach with all of our participants. So without further ado, I'm going to close it out. And I do recommend that if anybody would like to learn more about some of the things that we're up to in HIV and healthy aging in the state, just give us a buzz, give me a buzz, or Patrick. Until then, take good care, and thanks again. Be well.